We have a growing amount of data after COVID. As you very well know, ECMO was very popular during COVID, and we had plenty of patients. And one of analysis was performed in Europe with 600 patients who survived, and unfortunately another 600 who did not survive. And these were the causes of death. But what is even more interesting in these patients is how many of them were returned to work after 6 months. So 24%, that was a bit less compared to non-COVID ARDS. But what were the reasons for not returning to work, and what were the main complaints? That was dyspnea, first of all, but also persistent cognitive symptoms. The complaints were reported via telephone interviews, so that was not very objective. However, the numbers are quite large, and therefore the outcome of the study is very interesting. As you can see here, after 1 year, 40% of patients returned to work, which was twofold higher the number compared to 6 months. So the improvement in their function is continuous after some time. And as you can see, it's not only about physical or mental, it's also about emotional sequelae. And as you can see, post-traumatic stress disorder is quite frequent in these patients, not only in those patients, but also in other patients who survived critical illness in the ICU. This was very interesting because this was a prospective study performed in Italy, and even though the numbers were not very high in this cohort of 22% of patients, there was some in-depth investigation and diagnostic workup, as you can see, including their muscular function. And as you can see, this muscular function was significantly decreased in the survivors of ECMO due to COVID associated ARDS. This is interesting also because you can see that in this group described by a French group, there were only approximately 40 patients, but you can see that their neurological function in survivors of ARDS supported by ECMO or non-supported by ECMO, their neurological outcome was overall more or less the same. So that means that probably ECMO per se does not make their long-term prognosis in terms of neurological outcome worse compared to conservative treatment. And these are our results after 6 months after survival of COVID-19 ARDS treated by ECMO. Approximately 50% of these survivors returned to work, and 25% of them displayed symptoms that were similar to post-traumatic stress disorders, and among physical complaints, dyspnea was the most prevalent. Also, after resuscitation, supported by ECMO, the so-called ECPR, their long-term outcome was pretty good in this preliminary study, but also in other studies. And this was probably one of the most famous studies. This was Prague out-of-hospital cardiac arrest trial performed by Jan Belochlapek and his group. And as you can see, the survival was pretty good even after 8 years after cardiac arrest and support with ECMO. Also, neurological outcome after 8 years was quite good. That means that this very, very costly method of saving lives is not only efficient in very selected number of patients, that's for sure, but it also yields significant benefit even after long term. Also, in these patients, after 10 years, you can see that long-term survival and quality of life was quite good after 10 years. So all in all, we can see that ECMO makes sense not only to save lives, but also to provide a reasonable quality of life, which I believe is really something that we should focus on, not only in ECMO patients, but in intensive care in general. We focus on survival. Sometimes during our night duty, we focus on survival till the morning, but we should also focus on long-term function of these patients. It's quite interesting that these patients develop emotional distress similar to post-traumatic stress disorder. And not only these patients, but also their families, they all require multidisciplinary support after they leave ICU. And I think that if we have an ICU, we should have a post-ICU clinic to support these patients, but also their families, because they are all affected by the symptom called post-intensive care syndrome. Another short topic should be prone on ECMO. Proning is very effective. We all do this, that's for sure. We learned to do this very well during COVID-19. But should we use proning during ECMO or on top of ECMO? That's quite an interesting topic. Unfortunately, during COVID, a proper RCT was published last year. And as you can see, there was no benefit of proning patients on ECMO, even though proning on ECMO is not as difficult as you could see. This is a machine developed by our colleagues. It helps us a lot to prone the patients. You need only 1 to 2 operators to prone the patient, and you have full control of the cannulas. This is really interesting. It not only makes it easier for the staff, it also makes the whole procedure way more safe. So there were multiple reports saying that proning on ECMO makes sense, it improves oxygenation, and it might probably improve the outcome. Unfortunately, the recent study on ECMO brought contradictory results, but everything before that showed that proning on ECMO probably helps. So even prolonged proning, like 17 hours a day, was feasible on ECMO and tended to yield benefit in these patients. So all in all, it seems that proning might help, probably not in the most severe patients with COVID-19. As you can see in COVID, this difference was not so significant. And this trial was quite special because, as you can see in the methods, the compliance in these patients who are put in prone position was exceptionally low. Exceptionally low compliance means very little amount of aerated lung, very little size of baby lung. And probably if you have most of the lung collapsed, then proning makes no difference at all if you can at the same time ventilate the patient in a very gentle way. So if ECMO helps you to provide very gentle and lung protective ventilation and the lung is completely collapsed, then proning the patient doesn't make any sense. So to summarize, the long-term outcome in ECMO patients is generally not so different from other critically ill patients. In survivors of VV ECMO, which for us intensivists is probably the most interesting, respiratory complaints were most prevalent after several months or several years. Please do not forget about their mental and emotional complications and post-traumatic stress disorder is a significant issue, and we should get prepared how to cope with this. And I strongly believe in post-ICU care. So not only the patients, but also their families probably need support in that regard. And also the short topic of proning of ECMO, it's probably non-effective in most severe ARDS when the size of the baby lung is exceptionally low and the patient can be ventilated in very, very gentle way because ECMO allows this, because you don't have a ventilator at all if you don't wish to. So this is all for now. Thank you very much, and I'm open for questions.
Any questions from the floor? Okay, it's let me warm up the discussion. So I'm very happy that you mentioned the family issue and the importance of having family on the ward, because in Eastern Europe and also in Hungary we have a major conceptual problem that we have restricted visiting hours. So what is your opinion, especially in ECMO patients who are really the most invasively treated patients? So what is your opinion on the role of family restricted or liberal visiting hours and its importance in outcome?
Yes, that's a very valid point. I think that we tend to have very paternalistic pattern of medicine in general in our part of Europe, and in intensive care in particular. And we have to probably shift focus more to the patients and their families, not necessarily only our staff and ourselves. Because without their support, the patient tends to have more delirium, they need more sedation, their overall stay is longer, probably also physiotherapy in our part of Europe is not so easily available in our units, and the families could be also very helpful in that regard. On the other hand, the architecture of our units is still way worse compared to Western Europe. We usually have large rooms for several patients, and the privacy of these patients warrants very careful approach to these extended visits. If you can provide extended visiting hours for patients' families while guaranteeing the privacy of other patients, that would be probably perfect. So we have to provide good conditions in our ICU, and yes, we should think about their families, but not only during their ICU stay. I strongly believe that we intensivists should also provide the care for these patients after they leave the ICU and leave the hospital.
Yeah, thank you. I'm happy you mentioned the physiotherapist, because that was missing from your conclusion slide to me, the importance. And following this, what is your practice? Because you are running a large ECMO center, is that correct, Konstanty?
Yes, quite correct.
How many patients per year?
Oh, how to say? So we calculated the patients from the beginning of the year, so including our patients directly in our ICU and the patients in cardiac surgery, that was 50 patients from the beginning of the year until July, so 100 per year.
Per year, very good. And I just recently read an article that even patients on vasopressors should be mobilized beside the bed, right, by physiotherapists. So what is your practice? Do you mobilize your ECMO patients, and up to what degree?
We do. If you are able to wake the patient and control their respiratory effort at the same time, which happens to be an issue sometimes, and you cannot wake them completely because of their excessive respiratory effort. But if you can, then we mobilize them, and our longest ECMO run was approximately 145 days, and the patient was not bedridden. He used to sit in an armchair, make a short walk around the room, and he had a lot of physiotherapy and frankly some fun out of life. So because we have to provide that, especially in the long runs. But this is not so easy. You need a very large team of people, because to mobilize the ECMO patient, you need at least 5 people in this room, which happens to be difficult.
Thank you. Well, for the sake of the time, we have to move on. But Milos is here with us, so if you have any further questions, then he will be able to answer, because Konstanty and Milos, they work side by side in this department. So, Konstanty, thank you very much for joining us. We are really missing you here, but possibly in the near future you can attend. And congratulations to your new appointment as medical director of the hospital. And we wish you good luck and good health. Thanks.
Thank you very much.
Bye-bye.
Thank you, Zoltan.
Thank you, Konstanty. Bye.